Good day. I am Sherilyn Francis with the National Center for Primary Care, and we welcome you to part 2 of our 4-part Readiness for Adherence webinar series. At the NCPC, we invite you to connect with us via social media at Care Matters and at our website, www.primarycarematters.org. Today's webinar is brought to you by a partnership between the National Center for Primary Care at the Morehouse School of Medicine and Novo Nordisk. The NCPC is a national resource for encouraging doctors to pursue primary care careers, for making primary care practice more effective, and for supporting primary care professionals in serving underserved areas. The core principles of the NCPC are access, effectiveness, and equity. And now a few housekeeping measures. As participants, your microphones are muted and shall remain muted through the duration of the presentation. We ask that you check your internet connection for an optimal audio and visual experience. We ask that you refer all tech issues to the tech support chat pod, and we ask that you refer all presenter questions to the same chat pod. There will be periodic stopping points for question and answer, and there will be time designated at the conclusion of the webinar for discussion and questions. The objectives for today's webinar are to discuss the incidence, impact, and drivers of medication non-adherence for racial and ethnic patients with diabetes, to critique the practice of prescribing insulin to address poor outcomes associated with medication non-adherence, and to analyze GLP-1 agonists to address poor outcomes associated with diabetes. I present to you today's webinar entitled Unlocking the Keys to Effective Insulin and Incretin Mimetic Therapy in Racial and Ethnic Underserved Populations, presented by Ms. Sabrina Jackson and Dr. Christopher Holloway. In compliance with ACCME guidelines, the following presenters have no financial or other relationships with the manufacturers of any commercial services discussed during this educational activity. And now, Ms. Jackson.
Thanks so much, Sherilyn. I hope you guys can hear me okay. I'm getting a message from WebEx saying that there is something with my audio connection. So, Sean, if you can hear me, would you give me a thumbs up because I can see you? Okay, awesome. So, thanks again, Sherilyn. And to our audience, I'd just like to welcome you. If there are any on today who were here last time, I mentioned that this 4-part webinar series was going to be a continuing conversation. And so we have with us today Dr. Christopher Sean Holloway here to do the discussion for part 2 of this webinar series. So welcome, Sean. I'm so glad that you were able to join us today.
Thank you, Ms. Jackson. It's a pleasure to be here today, and we thank everybody for tying in today. We hope you associate value with this webinar series, and more importantly, we hope that you can make an impact on your patients to try to reach that health equity in all patient populations here in the U.S. and abroad, because we know that some individuals will sign into this webinar that log in abroad of the U.S. So welcome everybody today.
Thanks so much. Now, today our format is going to be a little different. There'll be a lot of question and answering throughout the presentation. So we encourage you, like before, is that if you do have questions about the presentation, and please feel free to submit them, and we'll get to them as we go through. We really want this to be an engaging conversation today. So, Dr. Holloway, and I'm going to try to remember to call you Dr. Holloway since I'm Ms. Jackson. But,
okay.
you know, in thinking about the topic, you know, there's a lot. When you look at this webinar series, look at the objectives, there's much about insulin adherence and diabetes. And I know I've looked at your slides, and I know that today we're going to spend a bit of time talking about heart disease, cardiovascular disease. So why don't we get started by you just telling us, you know, why is this relevant? Why is cardiovascular disease relevant in a conversation about diabetes and insulin adherence?
Yes, thank you. That's a great question, and we really want to address that question because really that's very important for a number of reasons. But the main reason is what causes the question has come up, and UKPDS and several other landmark trials have proven this, but what causes morbidity and mortality in patients with type 2 diabetes? And it's cardiovascular disease, and we see that in our clinic here in East Point, Georgia, where we talk to patients and we tell them, you're not going to per se, we don't want you to die, but you're not going to per se die of diabetes, but it's the cardiovascular disease. And then the question that they pose to me and to the rest of our team is, what is cardiovascular disease? And in layman's terms, that's stroke. Really, it's kind of the three-headed monster. It's stroke, myocardial infarction, and heart failure. And we know that moving forward, and the FDA has come out, and we can talk a little bit later about this, the FDA has come out and said for new drugs that come on the market, they have to show whether they're making an impact in cardiovascular disease. And so that's why we deemed it necessary to talk about this today.
Okay, awesome. So, so why don't we dive right in? And we know that probably on this call there are lots of diabetes professionals, and so seeing this slide is nothing new. But talk a little bit about the causes of mortality. You mentioned that briefly, but tell us a little bit more about that.
Yes, and we are trying to make this this presentation a very interactive presentation, and I'll do my best, Sabrina, to notice I said Sabrina, okay, to advance the slides.
Okay.
But yeah, the cardiovascular disease, again, it's stroke, myocardial infarction, and heart failure. And you can see this slide that's up here, and we don't want to read to anybody. That's not the point. But the point is when you look at the prevalence and the incidence of diabetes in America, they're both increasing, and we do see a disparity there in our population here that just so happens to be in a medically underserved area, and that's problematic because at that point in time we know that in racial and ethnic minority populations, we know that the prevalence and the incidence is higher for that. So we have to be an advocate for them, and for a number of reasons, but for most importantly, it's the right thing to do because, again, like we said, we see this disparity, and when we start seeing that disparity, the problem with that is that you have the lack of health equity across populations, and I know that there's different definitions of health equity, but by and large, the common denominator in all of those definitions is opportunities are taken away, and it may be that those opportunities are taken away indirectly or directly, and that's what today's webinar is all about, is trying to make everybody aware of that. Okay, so we talked a little bit about different racial and ethnic minority populations. This is data from the CDC. You can see the time frame for that. But if you'll notice of those races there, you'll notice African American, the prevalence is the highest. And if you were to also look at the incidence, it's the highest in that population as well. And so I want to bring that to attention. It's probably nothing new for anybody, probably nothing new for anybody else. But what's important to note is when you look at hypertension control, okay, it's not the same across all populations, and that's where we see that health disparities. And then when we further cut the pie open, when we start looking at different ages and different ages and the sex of people, we see differences there as well. And so one of the other things that's important to talk about is the question has come up, is the mortality from type 2 diabetes higher in racial and ethnic minority population versus non-racial? And the answer is yes, it is. And that's what this slide kind of leads into right here, is prevention of cardiovascular disease in those patients with type 2 diabetes. And for this is probably nothing new for the physician and physician extenders out there, but really the whole purpose of this is, you see in the slide, it's a circle, and it's in a revolving circle. And the question becomes, if what's more important? Is it the blood pressure that we have at goal, or is it the A1C that we have at goal? And we know from several landmark trials, the blood pressure at goal is more of a predictor of macrovascular disease reduction or cardiovascular reduction rather than the A1C. So that's something that's important to talk about, and we'll also talk about in a few minutes here on one of the other slides. Right there I have listed for you the blood pressure goal according to the ADA Standards of Medical Care 2017, which were released this year, and that goal has not changed. But last year there was a new trial that looked at high-intensity blood pressure goals of less than 120 over 90, and it's important. We'll talk a little bit about that and how that's relevant. Also, we have to look at the statin use and why that's important, as well as the A1C. Okay, so then the question comes up, and I'll kind of ping this back to Sabrina there. What are ways to reduce cardiovascular disease? That comes up, right?
Of course it does.
Yeah,
because, patients will have modifiable risk factors, and then they'll have non-modifiable. So you can't help that you have a family history. You can't help that you're African American. So the question comes up, what are ways to stop it, to reduce it? Yeah,
and so when you look at CMS, Center for Medicare Services, they evaluate and or grade health system practices on adherence to blood pressure medications to that goal. Okay, they also measure you adherence of statin medications. What percentage of time, or what percentage of your patient are adherent to their statins? Ironically enough, they don't. Now that the cut marks are no longer there, they do not measure. The CMS does not measure and evaluate health system practices on whether the LDL is less than 100, like the ADA recommends. Much in part because the ACC and AHA they have done away with those monitors. And then the last thing that they'll measure is adherence to diabetes medications, okay, that reduce cardiovascular disease, and we'll talk a little bit more about that later in this program. Okay, so I mentioned this new trial, and we're not going. I don't want to. This is not a drug literature evaluation time, but the SPRINT trial was a new trial. You can see that it was published in New England Journal in 2015, and this trial looked at intensive, and that's defined as less than 120 systolically versus standard, which is systolic of less than 140. The main follow-up on this prospective trial was 3.2 years, and it was terminated early because they reached the primary outcomes early. It was significantly powered to detect the appropriate amount of risk reduction. It was significantly powered to that, and their primary endpoints was, as you would note, that myocardial infarction, stroke, heart failure, and cardiovascular death. And so one of the things that's not listed there on that slide, but I want to share with everybody, is that the generalizability of this study that was conducted by the National Heart, Lung, Blood Institute here. And in this study, and we don't always see this, Sabrina, but in this study we had, if my memory serves me correctly, we basically had a third of these patients were African American. And so that should ring volumes with everybody out there, because we have been lobbying that clinical trials with our federal money needs to be, racial and ethnic minority populations needs to be included in this trial. And now we have a landmark trial. It's called the SPRINT trial. We have this landmark trial that shows that lower blood pressure, now it's going to come with some unwanted adverse effects like acute kidney injury and so forth, but it's reducing, okay, in the population that we know the highest prevalence and incidence of cardiovascular disease. So I just don't feel like I would be doing my job if I didn't bring up this trial for everybody to look at, okay?
Gotcha.
Okay. So again, this is just a brief synopsis of the results. And you can see whether it's absolute risk reduction or relative risk reduction, you can see those go down. Now what's important, and I'm not a biostatistician, as I'm sure that there many in the audience out there. I'm a clinical pharmacist, but the number needed to treat, and you can see these numbers for the primary cardiovascular outcome of 63. And there may be some that are in the audience out there that says, okay, well, Guy, why are you memorizing the number needed to treat? Put that in perspective for me. Well, for those physician and physician extenders, if you'll remember, ACE inhibitors are standard of care for patients with heart failure, right? And the number needed to treat with ACE inhibitors is right around 50. And so now you see the number of people that we need to treat. And so that number of 63 there is pretty close to 50, according to my calculation. So if you do some subgroup analysis of the SPRINT trial, what you can see is there are some variances there, and I just wanted to show this to everybody, but not spend a lot of time on this. The question may come up the question may come up of which medications are used by patients with type 2 diabetes reduce cardiovascular disease. Okay, and we've known for quite some time that metformin again and again has been our proven go-to workhorse, and we know this because it's been the first line drug agent for patients with type 2 diabetes, and now we still extend that to patients with type 1 diabetes for its reduction in cardiovascular disease. But there were two trials that have come out, one with a GLP-1 agonist, liglutide, a brand name Victoza, that has shown that it reduces cardiovascular disease. And then another category of medicine, the sodium GLUT2 transport inhibitors, empagliflozin, brand name Invokana, reduces cardiovascular disease. And so this past year is a significant year because we went from having one agent that reduces cardiovascular disease in patients with type 2 diabetes to now we have 3 agents. Okay, so I wanted to make everybody aware of that, and we'll talk a little bit about that as the webinar progresses. So,
And Dr. Holloway,
go ahead.
Dr. Holloway, I wanted to ask a question now that I see this slide here. I thought maybe you were going to weigh in on it about this medication adherence at 80%. And then for you to talk a little bit about the difference between medication compliance and adherence.
Oh, that's a great question. And because some people think it's the same, but it's not. Compliance is, well, first of all, you have to understand the relation between the physician extender, and the patient. And the patient somehow, some way, either is going to get the prescription filled, either because they don't want to be judged by the physician or a physician extender, or they seek value in it. One of the two, or maybe a combination of both. But compliance, nonetheless, is getting the medication filled, but not taking it as prescribed by the prescriber. Versus adherence is getting the medication filled and taking it exactly how the prescriber indicated for you to take that. And that's important because, as this slide shows, CMS, or Center for Medicaid and Medicare Services, they define medication adherence as 80%. Okay, and we all know that as comorbidities go up, what happens to the likelihood of medication adherence? It typically goes down. And if we apply that to the topic of our webinar today, what we see is typically is that triad of symptoms. Those patients that have hypertension generally have hyperlipidemia, and they may or may not have type 2 diabetes. And so those are the 3 chronic comorbidities, and that's important to note.
Now, what do you attribute that seesaw to, the increase in comorbidities and the decrease in medication adherence? Is it a complexity of regimens? Is it a matter of chronic disease distress? What do you attribute it to?
Well, again, it's multifactorial. When you're looking at when you're looking at the adherence, as the comorbidity is going up, medication adherence going down, some patients will tell you they're still in that denial phase, that I don't have this,
Right.
that I can do better, I can modify my diet, I can get this on the right track. But the likelihood of that happening is very low, unfortunately. The likelihood, it's not impossible, but it's certainly going to require a lot of education. That's the common denominator. Because, again, we're trying to, those comorbidities, we're trying to reduce cardiovascular disease, okay?
Gotcha. Thank you.
So I think everybody is familiar with this dimensions of adherence, and we find this, we could probably spend 40 minutes just talking about this, but unfortunately we don't have that kind of time. But the reason I think this, they say a picture's worth 1,000 words. When you look at these dimensions of adherence, and when you look at different racial and ethnic minority populations, there are a lot of social determinants of care that these patients may or may not be in control of, okay? And then you have the healthcare system. Can they access it? Can they access it at a time that's conducive according to their work schedule, okay? Or whatever the case may be. Then you have condition-related problems as it deals with adherence, and that could be, are they ambulatory? I may be thinking in terms of Atlanta, but can I get on MARTA bus to get on the MARTA train to get to my doctor? Okay.
Or
they may have yes, or to the pharmacy, exactly. Other patient-related could be, do I have access to care? Okay. Do I have access to go pick my medicines up? Okay. Do I have to choose between, do I want to pick my child up at school, or do I want to go get my medicines today? Okay. Can I go? I work during the day. The clinic's not open on the weekend. I have to go pick my children up, and I'm working a second job at night. When am I going to take care of myself, because I want to take care of my children first? And so it's just a milieu of different conditions that really impact adherence. And we have to be advocates. The way we look at it at our clinic here, we have to be advocates for our patients. Okay.
Dr. Holloway, before we go on, I do want to delve into that a little bit more, because I don't know how many people are in our audience. I don't really know the practice sites where they work and what their patient population is. I believe that people probably came because they were interested in probably some of the newer insulins. But here at Morehouse School of Medicine, one of the things that I feel like we're blessed with is that we can look through things, look at things through an equity lens. Yes. I know for a lot of people, they don't see equity the way we see equity, because it's in the wall, it's in the fabric of our organization. But we know that more and more what we're seeing in this country is that differences exist, and there are a myriad of drivers for those differences. But I wanted to talk a little bit about me as a provider in this arena of healthcare reform, and not knowing what's going to happen with the ACA. But even before the ACA, providers having less time to do more, basically. And now that we're looking at quality-based reimbursement, the pressure is on. We've got to perform. We've got to get it in. We've got to get in and see the patients, and we've got to ensure that the patients are doing their due diligence for what we ask them to do. And then it's my responsibility as a provider. And so I'm just wondering, looking, you're a CDE, you're a pharmacist, you work in a medically underserved area with a patient population that we're addressing. Wow, there was a long setup for this question, so wow. So my question is, what kinds of advice would you give folk who are out there on the front lines getting slammed every day to help with that whole adherence? Because you can't get a patient to be adherent, even with the CMS definition of 80%, unless you know what's driving them. But how do you get at whether or not you're really taking your medicine and having a client to tell you the truth? I had shared that I was at a health fair doing a screening at a local pharmacy, and this woman shared with me that every month she did pick up her prescription for her high cholesterol, her hyperlipidemia. Picked it up every month like clockwork. She wasn't taking it. Her provider didn't know it, but she shared that information with me, a total stranger.
Yeah.
So how do we ask the right questions to get at the answer? You know, am I going to ask them to bring in their pill bottles and let's count pills? Is it relationship and trust? How does that work?
Well, that's a great question, and there's not just one clear-cut answer. I think first and foremost, one of the things I want, before I answer that, I want to talk about, and everybody I'm sure knows the HEDIS measures, but CMS, that there are 5 triply weighted options that CMS. You talked about pay for performance and reimbursement. CMS, there are 5 triply weighted options, and is your patient's A1C at goal? What percentage are at goal with that? Is their blood pressure at goal? They're still saying that's now less than 140/90 in most of the populations, less than 140/50 in our elderly populations. But realize the other 3 triply weighted options are medication adherence to their blood pressure medications. Are they on an ACE or an ARB? I know that I know, as well as everybody else out there, knows typically that African Americans, they're not high renin producers, okay? But we don't put African Americans on ACE inhibitors and ARBs to control their blood pressure. We're putting them on that to minimize the damage to the arteries that innervate the rest of the organs of the body, okay? So that's adherence to that. The other category is diabetes medications, but it's important to note here, insulin is excluded from that because we all know it's titratable, okay? And then the third category is adherence to statins, okay? Adherence to statins. So to answer your question, I think first and foremost, health system practices have to realize these are all triply weighted. So they carry a high impact in terms of how CMS is evaluating health practices. Now, the United Healthcare, the Blue Cross Blue Shields, the other major insurance companies, guess what? They're evaluating our health system practices as well in that regard. But to get to the heart of the matter of your question, I don't know if I have a cookie-cutter answer to that. But I think there's some value in what you said, and it's about relationship establishment. It's about letting patients know that we care about you, okay? And we don't want to just treat you as a number and kind of herd you through here and herd you out. And so what we've done is we've created a group diabetes visit here, which is a shared medical appointment coupled with diabetes self-management and education. And it typically is the first and third Friday of every month, and we generally have anywhere from 4 to 5 patients there. And the first thing we let them know is that we're so glad that you came here because we care about you. We care about your health. We want to educate you about exactly what we're educating you guys about today because that's important to us. And what we see when we look at our analytics from this group diabetes visit, that's a shared medical appointment, and diabetes self-management, a key word being self-management education, is we're seeing a higher, we see a very, very low no-show rate with that. And when we're starting to look at our analytics on blood pressure goal and A1C goal, we haven't quite finished analyzing all that down on an annual basis, but I can tell you when we look at the A1C control of our whole population of our Morehouse Healthcare, it has more than tripled. It's more than tripled and increased towards goal. And so I'm not saying that's exactly related to our group diabetes visit, but somewhere in there, patients acknowledge that they like coming to that visit. They like coming back to the visit because it's an interprofessional type of delivery. We have attending physician, the resident physician, myself. We have a dietitian there, and we hope to have a physical therapist get involved in the future. But I think it's a chronic care team that really centralizes the patient, and somewhere in there, I think that somewhere in there, I hope that's the answer to your question.
Okay. I wanted to pause. I just, to our IT support, I don't know if you guys can pop up a poll, but I wanted to know if we can poll the audience. If not, I just need you to instruct me what else to do about how, just who in the audience feels, how they feel, if they feel that they have the adequate time to educate their patients about medication and therapy regimens. And I'm wondering if, one of the things I thought about, Dr. Holloway, as you were talking, is the benefit of having a pharmacist on staff or having a pharmacist as a CDE to do a lot of that education. We had talked a little bit offline that many times patients have secret fears about medications and about, their regimen, about the complexity of it. Just, it's a lot to get wrap your head around.
Yes.
But oftentimes your time in the exam room with a provider is not adequate. And I'm just wondering if there are providers out there that, feel the same way, that from their end, they don't feel like they have enough time.
Yeah.
I think this is a great time for the participants to potentially use the chat box, and they could put their response just in the chat box, just so we can get a good idea of what their thoughts are and what their take is on that question. I think that's a great question.
So if you feel like, yes, you do have enough time to adequately educate your patients on, medication and therapy, then say yes, and if you don't, then say no. And the reason I brought that up, because I thought it's, it is part of relationship, is having time, but also just imparting information. Sometimes the patient is not clear about what should happen, and
we hear
therefore
that from
Go ahead, I'm sorry.
We hear that from our resident physicians all the time, that I just don't have time to talk to my patients, or I don't have enough time to talk to my patients. And remember, with our group diabetes visit, I said that our resident physicians are in there, and they come to our group diabetes visits, and a lot of our resident physicians, they want to come to that because they want to have more time to talk to the patients. And they'll be the first one to tell you, because they're in the trenches every day. In addition to other primary care physicians, if you just give me the time to do this, I can do it. I'm educated. I'm well trained. But it's going back to that circular wheel. It's the health system, the way it's designed in terms of volume, that gets a bit challenging.
And Richard, I don't see any responses. I don't know if no one responded, or for some reason I'm just on a different view, so I don't know if you guys can see.
We are getting a few responses.
Okay. Yeah, I don't know. Maybe I'm on the wrong view or something. I'm not able to see it.
So currently, it looks like the majority of the responses are not in the affirmative. So we have a no, I don't believe so. Let's see. We have an I am a community health worker, so I do take the time to help patients to understand the instructions that providers give.
Yay, community health workers. That was the other door I was trying to open. Is the benefit of a care team.
Yes,
and I think one of the beautiful things that community health workers bring to the table is the ability to help form relationships, trust relationships. You are professionals, you're experts, and you have the time and the expertise to form those relationships that our patients need. So kudos to our CHW in the audience, and for those of you that don't currently use community health workers, you should start. We have a training program here at Morehouse at MSM, so we're very excited about what is happening on the landscape about community health workers and certifications training, and just elevating the importance of their role in not just diabetes but chronic disease management. So
that's exactly right.
Yeah, so sorry I got us off track, but
well, I have another interesting perspective.
Okay.
So we have one participant who is they are associated with a nonprofit organization, and they have the ability to spend time with their clients and teach them about medication adherence.
Awesome.
That is outstanding. We thank you for that feedback.
And that is another key point that you brought up, though, a nonprofit. So, Sean, you talked about our medical system and how, the truth is systems do what they're designed to do. But
Yes.
now we need system redesign and having community partnerships, having trusted organizations in a patient's environment that you can leverage to do non-traditional things. So having a diabetes self-management class at a YMCA, or at a church, many best practices are starting to emerge where that's working because it's connecting with the patients in a way that's meaningful to them. So I'll stop,
Absolutely.
put my soapbox away, go right ahead, sir.
No, no, not at all. This is great feedback. I
Yeah,
mean,
nice.
we're all very passionate about being an advocate for those that sometimes these patients feel like they've been written off. Nobody cares for
Right,
them. Nobody wants to
right.
be an advocate for them, and that's certainly not the case. And the other part to that, here at Morehouse School of Medicine, I mean, I have my pharmacy students, they're medical students, so it's not only that we're providing this standard of care, but we're trying to teach it to pass that on to the next generations to
Yes,
come.
yes,
Yeah,
yes.
so it's the whole concept of force multiplication, and so whoever that individual was that talked about adherence, that is so valuable. I'd love to have an offline discussion and listen to that individual, to what they have to say. But I think one of the things to talk about is, and I get this question a lot, is, okay, you have a dashboard and you have to be adherent 80% of the time to these medications. And now remember, adherence is measured kind of retrospectively, okay, because we're having to go back in time and look at that. And I know one of the analytic dashboards that I look at on a monthly basis with our patients is I'm looking at it on a granular level. So if you get a calculator out and you multiply, most people are saying, "Man, this is not a math class, okay?" But just behoove me. But if you get out that calculator and you multiply 80% times 365, what you'll see is you'll get a number, and that number is how many days can patients miss their medication. Like, for instance, I was just looking at one of our reports of how many patients do we have now that is approaching that 70, that's approaching what we call, it's either are the patients in the green zone, the yellow zone, or the red zone. And right now they've already missed the majority of January of their medication, okay, in these three categories. And so that kind of puts them in that red zone, and it allows me to proactively monitor them. Hey, what happened? You know, because if we don't get them out of that red zone into that yellow zone, then they're not going to be adherent the rest of the year, and that hurts. Well, for one, it hurts the patient, but for two, it hurts us in terms of CMS and other insurances, because it makes it look like we're not educating our patients appropriately for them to take their medication. So, you know, all of that's built around that 72 days which they're allowed to miss. And I just have this slide right here. And for those who may not be able to look at this, if you will look at the year this was published, this is in 2005 in medical care. And investment in medication adherence leads to reductions in overall cost of care. Now, this was looking at patients with diabetes and so forth, okay? But we can see that adherence, and that's why CMS measures health system practices on that. That's why the STAR measures measure pharmacists now that work in a retail pharmacy. What's your STAR rating as it relates to chronic medications like diabetes, hypertension, and so forth? So pharmacists are getting evaluated on if their patients are adherent or not in a retail pharmacy setting. So this concept of adherence is very, very important.
And Dr. Holloway, that information was strictly compiled from refills, so looking at pharmacy data.
Yes.
Okay.
Yeah,
Gotcha.
and that's the really only true way that you can look at adherence is adjudication claims. So what that means is when the patient gets a prescription filled, it goes either to CMS or the insurance, and then it comes back. And now it's important to bring out, because sometimes the question will come up, well, how is that measured? Remember, adherence is not measured when they get the first prescription filled. Adherence is measured the day one they get the first refill, okay? And so having said that, the question comes up time and time again, from our attendings in our department and other department is how can we improve our adherence, okay? And the first thing that I tell patients, attendings and the like, is that we need to be prescribing for patients for diabetes that have hyperlipidemia and hypertension a 90-day supply. There should never be a reason why we're prescribing a 30-day supply. It should be a 90-day supply with 3 refills, because then if they start that metformin and they have 90 days, and we know that there's a high incidence of GI problems, there can be a high incidence of GI problems. There can be, that's right, can be. Hopefully we're going to prescribe that extended release once a day at bedtime after they eat meals, and it's going to be a moot point. It won't have any problems at all. And but generally, if they happen in that first 90 days, if it happens, we can generally resolve it real quickly, versus in that first 30 days, see, they're going to go back and get that second refill, and they may not take that refill, and at that point in time, it really hurts the health system practice in addition to the patient as well. So 90-day supply is the key thing that we want to do.
And I noticed you said with the 3 refills, so you no longer believe in holding patients hostage to refills because they don't come in.
No, because
they've missed an appointment.
No, exactly, because that's one of the access problems, and that's a lack of equity problem, because why are you going to do that? That makes no sense. And we've educated all of our nurses. If they call in, they need the and we're not talking about any other categories of medicine. We're talking about these 3 categories specifically, and it's because we're trying to educate them. Listen, we want you to get your medicine. Yeah, and if you think about it, you look at the numbers, the 90-day supply with 3 refills, really they only have to go to the pharmacy 4 times a year, and we get them to get all their medicines. We sync the refills, okay, to where they pick all their medicines up at the same time, to where if they have transportation issues, okay, they're only going 4 times. And so, again, it's setting your patient up for success.
Well, but let me play devil's advocate a little bit. So if I don't attach their follow-up visits with the refills, then how do I know that they're taking their medications properly, or that they're not taking them? Because, like as you alluded, sometimes patients have side effects and they'll just stop taking their medication, and there's no way for you to know if they're not coming back in.
Well, one of the things, and this is certainly not the best way to do it, is you can always reach out to the pharmacist. But if they're going to different pharmacies, again, all roads lead back to relationship building with the patient, establishing that value that exists between the prescriber and the patient. All roads lead back to that. So
great answer. Let me just pause for a moment and see if we have any questions from the audience, as we are about a quarter till now. I think I did see something, and I for some reason it's just a weird view, but someone mentioned, how do you help a patient who, basically would like alternatives to traditional medications for diabetes and hypertension and hyperlipidemia management? I'm not sure if that's I'm trying to find the question again. I just was able to. Okay. So I think the question is, what about patients who want alternative to a life dependence on prescription medication? So you're dealing with the whole distress about having a chronic disease, and this is life altering. Yes. So how do you address that?
Well, the way I would address that, and the way we address that, is that you have to look at some parametric values before you can do that. Okay, and I don't know who ever asked that question, but it transitions well into this slide right here. And typically, when we're looking at the management of these of blood sugar, because of those advanced glycosylated end products that cause damage to the basement membranes of the arteries and so forth, when the A1C gets greater than 9, that patient there has got to go on insulin, because if not, it's only a matter of time. But when we see that A1C is greater than 9, those patients have to go on insulin. Otherwise, there's no regimen, whether it be prescription medication or whether it be any other types of alternative therapy that's going to get that A1C less than 7. So what does that mean? If they do nothing, they're going to eventually go into diabetic ketoacidosis, and that is certainly no way to be an advocate for your patient. So I hear what the patient is saying. But again, we have to do what's in the patient's best interest. And so at some point in time, and this is the conversation we have with our patients. You may be on insulin, but you won't be on them forever. Okay. Mm-hmm. Go backwards. Yeah, that one's it right there. So briefly, what I find people can associate value with is once that A1C is above 9, we need to put them on a basal insulin, because you can see here the relative risk of this microvascular disease, not macro, but microvascular disease that we've known for a long time is related to the A1C. Our goal A1C is less than 7. So when we're down here, yes, there may be another alternative therapy that they can use, but when that A1C gets above 9, they have to be on insulin. Metformin's not going to work. We're going to have to get them put on insulin to get that A1C around 7. Then we may not keep them on insulin. Then that becomes a conversation where they can associate value with a clinician. Mm-hmm. So I wanted to just put this up here. There's some newer agents that are out there in this era of which insulin do I pick, what's out there, and then the other GLP-1 agonists that we talked about earlier that decrease cardiovascular disease. The GLP-1 agonist that's out there, most people know it by brand name Victoza. Like we said, it does decrease cardiovascular disease. Okay, there's another new product that's out there. The Victoza is an injection that the patients give themselves subcutaneously, and then there's another product out there, empagliflozin, brand name Invokana. It's a tablet that also reduces cardiovascular disease. We have some new basally acting insulins that have lesser amounts of hypoglycemia that are out there. The insulin degludec, brand name Tresiba, is out there. It's a new product in terms of basal insulin for those patients whose A1C is greater than 9. And then another new product that just came out as a combinational product of the insulin and the GLP-1 agonist. And for those that may or may not know what the GLP-1 agonist is that medication has really 3 ways it works. 1, it squirts more insulin out of the pancreas, but 2, it promotes satiety, so it regulates those hormones in the gut talking to the brain, and so they feel fuller longer. They don't eat as much, and patients will lose a considerable amount of weight while being on this, and then it prevents that high glucagon release. So you don't have that high postprandial insulins. You don't see that high postprandial blood sugar that we see. And then we see the another basally acting insulin, the U300 for those that are on high amounts of insulin. The Torzeo, it's a U300. It's not the U100, so it's 300 units per ml. And then the brand new product that just came out last month that I believe is going to revolutionize how things are working is, and I may mispronounce this word, but exotrophy. And no, I didn't pronounce that correctly. But exotrophy. But it's insulin degludec and liglutide, brand name Victoza. And the rationale with this is those patients that are just on insulin and they're at their goal A1C, but they keep gaining more and more weight, and they keep increasing their cardiovascular disease. Okay, we want somehow, some way to put them on an agent to where we can keep their A1C at goal, but we also want to reduce their cardiovascular disease, and that's where this combinational product comes into play, and it's going to be so interesting. And I'm told that Novo Nordisk is doing fabulous things to make sure patients and racial and ethnic minority populations have a way to afford this combination product, and
Yeah, that was going to be my question. It's always the issue of access. So
that's exactly
yeah.
right. So I alluded to this earlier, but one of the things that the FDA talked about in 2008 here is if a company wants to launch a drug for diabetes, they have to look at, does it reduce cardiovascular disease? And again, there are two drugs that are out there. There are several GLP-1 agonists that are on the market out there, but none other than liraglutide or Victoza have shown to reduce cardiovascular disease. Okay, the SGLT2 inhibitors, there's several out there, but only empagliflozin has shown to reduce cardiovascular disease. So I'll just share this, and it could be a tale of two cities. The perspective nowadays may be that patients that have hypertension, hyperlipidemia, diabetes, they all have a high cardiovascular risk. They all have the highest cardiovascular risk. The day has come that maybe we need to put them on a medicine that's going to reduce their cardiovascular events that has A1C lowering capabilities versus the other way around. So it's kind of the tale of the two cities. So this is a slide here that talks about cardiac effects of type 2 diabetes, and what you'll see here is in these two categories here, they do what? They both that they decrease it. Okay. This is what I talked about. This is the IMPA reg trial outcome that looked at patients, and what they saw, the primary endpoint is the major adverse cardiovascular events, specifically cardiovascular death, non-fatal MI, and stroke. And this trial showed that this agent reduces that. And now it's interesting. I was talking to one of our cardiologists, and he says, "Yeah, empagliflozin is a great drug. I prescribe that for my patients with hypertension, hyperlipidemia." And I'm like, "Really?" And I'm like, "Do they have diabetes?" And he said, "No, but I don't care whether they have diabetes or not because it's only lowering the A1C of a point, but it's decreasing cardiovascular disease, and that's what I want to do." So different physicians have different perspectives about these things. This is the...
Dr. Holloway, I just want to pause for a moment and ask the audience if there are any questions, then please submit them at this time. We're about 5 minutes till the hour now, so we're coming up short on time. And I wanted to just ask you alluded to the fact that you were told that at least one pharmaceutical company is making, ensuring that that these drugs are going to be available to patients of probably low socioeconomic status. And I wanted to know, how would you advise providers who are out there, and even our community health workers who are in the audience, how do you as a provider find out that information to get it to your clients? Because they see it on TV, they're going to be asking. So
yeah, well, first and foremost, like I said, I have no disclosures, but Novo Nordisk is a company that it only deals with diabetes drugs. The owner of the company, his wife developed type 1 diabetes, and that's when he said, "I think I can develop a company to do something to help people." And what you'll see is they're all in the business of making money. I mean, if we don't make money, we can't support our families and so forth. And so I don't think we can judge anybody for trying to make money. But I do think that there's a big emphasis now on making insulin affordable. The ADA just sent out a petition trying to get people to sign that to try to put some pressure on these companies to lower their insulin prices and so forth, because they're so much more expensive in America than outside of America.
Right.
But one thing that I would highly recommend to all of those community health workers, physicians, pharmacists, diabetes educators, Novo Nordisk has their cornerstones of care, and that is a program that's free of charge to everybody out there, where patients have access to free educational materials. They have access to dietitians. They have access to diabetes educators free of charge. And Novo Nordisk sends all of these healthcare professionals out in communities that are medically underserved because they're trying to make a difference. They are trying to make a difference in this cardiovascular burden that is seen. in different racial and ethnic minority populations, and it's called Cornerstones of Care, okay? And I would highly encourage everybody. There's more information there that's free than what you could ever come up with on your own. And I say that myself. I mean, if I were to pan the camera here, you can see a lot of information that, like for instance, I'll just show this one book here. It's a carb counting book from Cornerstones of Care. It's free of charge, and this is written on an 8th grade reading level for our patients, and it's a very valuable resource. Hopefully the people from Novo Nordisk, they get flooded with calls. Hopefully they're not going to call me up and say, you told all these people this, and I'm like, well, that's what it's there for. It's for people to use.
And again, Dr. Holloway doesn't have any financial relationships with Novo Nordisk, just passing on information. There was a comment that empagliflozin brand name is actually Jardiance rather than Invokana. Yes. Just want to let the audience know.
Yeah, that's a slip of the tongue. I apologize for that.
Well, we have about 30 seconds if you want to summarize. I wanted to give you that opportunity, and then we'll turn it back over to Sherilyn. I definitely hear, though, that cardiovascular disease, diabetes is cardiovascular disease, and that is something that we need to have on the forefronts of our brains as we are educating and treating our patients.
Yeah, and that's the one thing that I would just echo is when it comes to cardiovascular disease, you got to think of the ABCs, and that's A1C, blood pressure, and cholesterol. Okay, and you got to think adherence of patients to their medicine. They may not be on the best statin to lower their LDL, but guess what? If they can't take it every day and be adherent, then it's no good. It may be that you need to get them on the one that's on the $9 list at Walmart, just so they can get adherent to where you can develop a relationship with them till you can get other resources to help these patients. So it's not all about the A1C. It's not just the A. It's the B and the C that comes along.
Thank you, Dr. Holloway, for loaning us your expertise and your time today. So with that said, I will turn it back over to Sherilyn to close us out. Thank you, everyone.
Thank you both, Dr. Holloway and Ms. Jackson, for an extremely engaging and informative presentation. We want to note that today's webinar recording and the full presentation slides will be available at www.primarycarematters.org. And we thank all of our attendees for participating in today's discussion. A post-evaluation will be issued with CME questions, and if you have any questions or requested resources, you can also submit those in the post-evaluation. And we thank you for your attendance in today's webinar.
Thanks, everyone.
A big echo thanks to everyone